Hello to you wherever you are listening to this. My name is Dr. Lenny Powell. I'm an assistant professor in the Department of Geriatrics at SOM. I was also in PBL many years ago, did my internship, my residency, and my fellowship here, and now I'm faculty here. So I've been here a while. My lecture to you is going to be on comprehensive geriatric assessment and using it as an approach to older adults. So following this presentation, you should be able to identify the components of a history and physical, identify the geriatric specific components of a history and physical, and how they fit into a comprehensive geriatric assessment, place an emphasis on functional status and the individual components of that functional status as the most important part of the comprehensive geriatric assessment, and develop treatment plans based on findings from a comprehensive geriatric assessment. So the reason why I am recording this in advance is because I want to spend more time with you in the lab doing things like cognitive testing, looking at functional status, instrumental activities of daily living, and other activities like that, rather than spending the time and going over the theory, which I'm expecting you to do beforehand. If you look at the components of a standard history and physical, you have chief complaint, HPI, review of systems, past medical history, past surgical history, family history, social history, medications, allergies, physical exam, laboratory data, imaging and studies, and finally your assessment and your plan. So that is great. That's what you are learning in this class on Doctoring 2. But in terms of your approach to geriatric patients, there's a couple of extra things that are emphasized, and that would be an expanded social history, a much more detailed functional history as its own separate entity of your H&P, as well as immunizations and preventive care screenings. So looking at the components of a functional history, there are 8 that I'm going to illustrate to you. The first is the CATS activities of daily living, also called the ADLs. The next is the Lawton instrumental activities of daily living, which are the IADLs. We'll look at a method for screening for depression. We'll look at some cognitive screening. We'll look at hearing and visual screening, use of ambulatory devices like canes or walkers, looking at falls, and nutrition. So, starting with the CATS activities of daily living, there is a reference in your PowerPoint where if you click on it, it will give you a little bit more detail in terms of what defines being independent versus requiring assistance versus completely dependent in terms of these 6 activities of daily living. So the 6 activities of daily living are bathing, dressing, toileting, transferring, continence, and feeding. However way you want to remember that, you will see this again in your 3rd year in the geriatric clerkship. You'll also see it if you go into any sort of medicine specialty and even surgical specialty when you're looking at discharging patients, having physical therapy see them and determine where they should go when they're leaving the hospital. If they should go to subacute rehab, if they should go home with home care services like home physical therapy, etc. So ADLs are also used to determine whether or not someone should be placed into a long-term care setting, for example. So here's a case for you. This is Mrs. Lamore. Mrs. Lamore is an 84-year-old female with severe dementia who was brought in for evaluation by her daughter. Her daughter admits that her mother has been requiring more help with basic daily care in the last few months, and she's starting to feel overwhelmed. She has interviewed and toured 2 assisted livings locally that have units specifically designed to cater to the needs of dementia patients. Mrs. Lamore is completely dependent for bathing and has been for some time. Over the past few months, she has progressed from occasionally incontinent of urine during overnight to usually incontinent of urine. She remains continent of stool. She toilets herself for both urine and stool during the day and cleans up after a bowel movement without assistance. Her mother has not had any falls since completing a course of physical therapy and learning to use a rolling walker. Her daughter also admits that she used to lay out her mother's clothes in the morning, but now really needs to dress her mother in order for her to look her best. Mrs. Lamore feeds herself and is typically a good eater. So, how would you score this patient on the CATS ADL scale? Where are her deficits? So just to review again, the 6 ADLs are bathing, dressing, feeding, toileting, transferring, and continence. So as the stem says that she is completely dependent for bathing, her daughter has to lay her clothes out and dress her, and she also is usually completely incontinent of urine. So the answer is C. Her ADL score is 3 out of 6 with deficits in bathing, dressing, and continence. Turning to the Lawton instrumental activities of daily living, there are 8 Lawton IADLs. They are telephone, shopping, laundry, transportation, meal preparation, medications, housekeeping, and finances. And again, there is a reference in your PowerPoint that I advise you to read in order to determine whether or not someone is independent, partially dependent, or totally dependent on their instrumental activities of daily living. So, deficits in the IADLs will usually lead to someone being placed in an assisted living, as opposed to someone who is ADL dependent, which usually requires long-term care or nursing home, what you would think of as a nursing home. So here's another case for you. A 77-year-old male with Parkinson's disease and COPD presents for routine evaluation and discussion of his present health status. He admits that my son has taken over my medications. This gentleman, whose name is Mr. Watson, had a series of falls 2 months ago. His son fortunately noted that several medications hadn't been refilled in over several weeks, strongly suggesting his father's non-adherence. Since that time, his son has been setting up a pill box for his father. Mr. Watson jokes he may have gotten my pills, but he won't get my bank account. Mr. Watson continues to do his own finances. 2 years ago, when Mr. Watson was first diagnosed with Parkinson's disease, his son encouraged him to quit driving and move up to New Jersey from Florida in order to be closer to his son. Mr. Watson recalls, regrettably, now I need to depend on him for a ride to the supermarket. Mr. Watson calls his son 1 or 2 weeks in advance to schedule an outing when he needs a car ride. He acknowledges that he depends on his son to help him with shopping because he has poor endurance, secondary to progressive COPD. Mr. Watson never did his own laundry, never did his own housekeeping, and never did his own food prep, noting, I had a housekeeper down in Florida who did that for me after my wife died. He goes on to admit that he feels fortunate to have a loving son who is just a telephone call away, but he never wanted to be a burden. So, the fact that this gentleman had his wife prior to a housekeeper who handled his laundry, his housekeeping, and his food preparation doesn't really work against him because there's a generational component to that, and sometimes men don't do all of their IDLs ever at any point in their life. Some of you may not even do them now. I do some, but let's not get into my life story. So how would you rate this gentleman on the Lawton IDL scale? He scores a 3 out of 8 because he has deficits in shopping. He has to ask his son for a car ride to get to the store. Medications, his son lays out the pill box for him. Food prep, housekeeping, and laundry, which he never did anyway. So the scoring there is not as severe, should we say, as if he had more deficits in his ADLs. Because like I said, he never did some of those things himself, so you can't really penalize him for not being able to do them now. Okay, so moving on to the next part of the functional status, which is the depression screening. So there are several different screening instruments that you can use. A screening instrument is just something to identify whether or not a patient has a condition. So a depression screening obviously is used to screen for depression. There are several, like I said. We'll talk about the PHQ-2 and the PHQ-9. There's also something called the Geriatric Depression Scale, and I'm sure you can find others if you look hard enough, like the Beck Depression Inventory. But we'll focus on the PHQ-2 because that is what you will see used the most across all of your rotations. So the PHQ-2 is the Patient Health Questionnaire 2 as opposed to the PHQ-9. PHQ-2 has 2 questions, PHQ-9 has 9 questions. PHQ-2 is a screening exam that asks, over the last 2 weeks, have you been bothered by any of the following problems? And it rates the answers on a score from 0 to 3. So the first question is little interest or pleasure in doing things. The second question is feeling down, depressed, irritable, or hopeless. And the scores are 0, not at all, 1, several days in the last 2 weeks, 2, more than half the days of the last 2 weeks, or 3, nearly every day. And depending on what that score is, that will determine whether or not you need to do the PHQ-9. If the score is greater than 3 on the PHQ-2, greater than 3 or equal to 3, I should say, then you should do the PHQ-9. You have the instrument in your PowerPoint. I'm not going to read it to you. It's similar, and again, there's a scoring rubric in your PowerPoint that lets you classify how severe the depression might be and what the treatment recommendations could be. In terms of cognitive testing, so being January 2018, in case I use this in the future, President Trump just underwent a physical exam, part of which included a cognitive screening, which used something called the Montreal Cognitive Assessment Screening. We call it the MOCA. It's the abbreviation for it. There is a article that I linked in your PowerPoint from the Washington Examiner that I suggest you read. And there's a picture of what the MOCA is. We will spend a lot of time in the lab doing what the MOCA is. You'll do it to each other. And there are some subtleties to it in order to determine if there are cognitive deficits or not. Trump scored a 30 out of 30. I'm not saying anything more about that. Let's not get political. Okay, moving on. Falls assessment and sensory impairment. So, sensory impairment, whether it's hearing difficulties, visual difficulties, can precipitate falls. So, you should always ask your geriatric patient, geriatric being defined as greater than 65, have you had any falls in the last year? If they have, previous falls are the biggest indicator of future falls. A way that you can assess fall risk is doing something called a timed get up and go test. And the way this is done, we will go over in lab. If there's less than 10 seconds on doing it, you're considered low risk. 10 to 20 seconds, you're intermediate risk. Greater than 20 seconds, you're considered high risk. And also, I mentioned in terms of sensory impairment, hearing difficulties, vision difficulties, but also, does the home have grab bars in the bathroom, handrails on the stairs, adequate lighting, and secure rugs? Okay, moving on to immunizations. Immunizations, just like when you're pediatric, have as much importance as when you're geriatric. So the main immunizations that we are focusing on are influenza, specifically the high-dose influenza given after age 65, the Prevnar 13 and Pneumovax 23 vaccines, which are given a year apart starting at age 65, and I'll show you a little bit of nuance with that because these guidelines recently changed. Shingles vaccine, which is 50% effective at prevention and 66% effective at preventing post-herpetic neuralgia. Tdap, which is the tetanus vaccine, as well as diphtheria and pertussis. That should be given every 10 years. And that should especially be given to grandparents that are around very young children, such as newborns and those less than a year old that have not yet been immunized. Lastly, hepatitis B, especially in the diabetics who are checking their blood sugars and have the blood exposure from doing that. You can check immunization status by obtaining something called a hepatitis B surface antibody, which is a blood test. So I mentioned about the pneumococcal vaccine and that they should both be given a year apart. So either Prevnar 13 or Pneumovax 23 can be given, and 1 year later should receive the one that was not given. Okay, so the next part of the comprehensive geriatric assessment deals with what's called advanced care planning. And the reason it's called advanced care planning is you're making these decisions prior to being in a situation where you can't. So advanced care planning deals with goals of care. Specifically, does a patient have an advance directive? Do they have a durable power of attorney who is somebody who would help make decisions for them should they become ill or incapacitated and not able to do so? There's another document called the New Jersey POLST form, which stands for Physician Orders for Life-Sustaining Treatment. It deals with medical interventions, artificial nutrition and hydration, CPR, airway management, and you'll learn more about this when you get on your geriatrics rotation. But I'm just giving you a brief introduction to it now. Next is preventive care screening. So there's an app, whether you have an iPhone or a Droid. I don't even know what all the phones. I have an iPhone, so that's all I know. But it's called the AHRQ EPSS app, and what this does is it lets you download an app that has grade A recommendations from the USPSTF, given age, given whether or not they use tobacco, if they're on blood pressure medicine, and if they're pregnant, what screening tests should be done at what ages. And this works for pediatrics, geriatrics, adults, anybody. So I suggest you download it because you will use it a lot on your rotations. Um, in terms of comprehensive geriatric assessment, both sexes should be screened for colorectal cancer with colonoscopy or some other test, hepatitis C if they were born between 1945 and 1965, and low-dose lung cancer screening of the chest with a CT if they were smokers. Females specifically should get mammograms and paps and pelvics, as well as DEXA scans for osteoporosis. Males should get PSA, which is prostate-specific antigen, as well as abdominal aortic aneurysm screening. Again, smokers are more prone to this than non-smokers. Turning to nutrition. So, factors that cause increased appetite include malignancy, hyperthyroidism, uncontrolled diabetes, malabsorption syndromes, pheochromocytoma, and a marked increase in physical activity. Decreased appetite can be caused by malignancy, chronic medical conditions, COPD, GI diseases like gastroparesis, depression, opiates, alcohol, and other iatrogenic causes, which means that medications like NSAIDs, metformin, digoxin, SSRIs, and acetylcholinesterase inhibitors will cause decreased appetite. Hearing and visual screening. Hearing impairment is associated with depression, social isolation, poor self-esteem, functional disability, and the way that you can assess this is either through observation, through otoscopic exams, doing a finger rub where you take your finger and just rub next to the person's ear like you're assessing cranial nerves, and ask if they can hear that, as well as whispering in their ear and asking if they can hear what you're saying. Visual impairment is not a normal part of aging. There's increased incidence at age 75, and not surprising, this is associated with increased fall risk. So an eye exam every 1 to 2 years after age 65 is appropriate. So in your slides, I have some pictures of what common visual impairment syndromes would look like. So cataracts, you can see the stop sign is barely visible. Glaucoma, you're missing a lot of the outer part of the cone of vision. Diabetic retinopathy, there's some darkening overall, and some other visual fields are obstructed. And lastly, macular degeneration, where central vision becomes blurred, but not so much the peripheral vision. Okay, so social history, as with what you've learned, look at alcohol, tobacco, drugs, occupation that your patient had, whether or not they were exposed to anything like asbestos, dust, any other possible occupational exposures that can lead to disease, what their living status is, if they live in the community, if they live in an assisted living, if they live in a long-term care like a nursing home, what their marital status is, if they have children, if they're involved in an adult day program, if there's stairs in their home, or other factors that can lead to falls. Aging differentiates us, and you have to be able to figure out what is it about the age of your patient that can affect them or harm them. So in addition to all of these factors that we just looked at, your complete history and physical will let you identify even more so what harms your patient will be exposed to. And by looking at the function, the whole goal of looking at geriatric patients is to maximize their functional status. If they fall, if they can't see, if they can't hear, if they are cognitively impaired, if they're depressed, if they're on medications that are affecting their ability to live their life to the fullest, those are the things that we try to maximize. The most important aspect in dealing with a geriatric patient is by maximizing their function. So that should be your take-home message. We're going to focus on doing the MOCA, looking at ADLs and IDLs in a couple of cases. We'll do the time get up and go test, and I will email you prior to the class the materials that I'll be using. So if you have any questions, feel free to send me an email. It's powelle@rowan.edu, or you can probably look me up in the address book. Okay? See you Wednesday. Bye. Thanks for listening.